Welcome back. We're meeting after quite some time. 3 months, 4 months, around Rover it was. Okay. So before we go ahead, we'll have an introduction of the new faces. You can just start off quickly, no?
Good evening, everyone.
Sit in, just sit in.
I'm Dr. Gunaranjan. I finished my DM from Ramchandra Medical College. And I'm from Andhra Pradesh, so I'll be going back in some times. Are you working now? Not yet. Like I'm with Basmani sir, as of now. And morning I'm going to Rela, just as an observer.
Hello all, I am Dr. Deepak, final year in Apollo Hospital, DNB resident. Candidate, DNB sir. Medical gastroenterology.
Medical gastroenterology.
I am Dr. Sadgundra, completed DNB from DNB Medical Gastroenterology from Apollo, now working in GEM Hospital, Chennai.
Yeah, hello.
Dr. Anand has joined this time.
First year surgical gastro PG under Sankar sir and SRMC.
I'm Dr. Dheeraj from I'm surgical gastro PG from SRMC under Sankar sir.
I'm Dr. Akhil, surgical gastro PG second year sir under Shankar sir.
I'm Dr. Aravind, third year PG surgical gastro under Dr. Shankar sir.
I'm Dr. Pavitra. I'm MRCS trainee from SIMS Hospital.
I'm Dr. Senthil Ganesan, surgical gastroenterologist consultant from Annayar Hospital, West Tambaram.
I'm Swarna, physician associate. I'm with Dr. Radhakrishna Pattas.
I'm Sunita. I'm a physician associate working with Dr. Radhakrishna Pattas.
Priyadarshini, working under Dr. Pattas.
I'm Humaira, physician associate working with Dr. Patta Radhakrishna.
Hello all, I am Dr. Rahul Mishra, second year surgical gastro DNB resident at SIMS Hospital.
I'm Magnus, SIMS Hospital senior consultant, surgical gastro.
Hello everyone, good evening. Myself Dr. Udayam, surgeon from SIMS Hospital.
Patta Radhakrishna, gastrosurgeon, Malar, MGM.
Ilan Kumaran, J surgeon, transplant surgeon at Apollo, Chennai.
So we have 3 cases lined today, followed by how do I do it session. Dr. Radhakrishna wanted it specifically every time. When it came from you, I thought I should ask what to do. Yeah, that's what I meant. Yeah. So we'll have 20 minutes per case. We'll try to stick to the timings because usually what happens, the first case drags on. There is less time. So we'll have 3 cases followed by 12 minutes for Piramas. So before we start up, I thought we'll make it a little interesting. Something. Who discovered pancreas according to history? Anybody can answer, not only PGs. iPhone only one name. This man is supposed to have discovered pancreas. He is supposed to have been an anatomist in Greek 3rd century BC, and he was the only one who was performing publicly anatomical dissections, and he discovered pancreas, but he didn't name it. So that's the next question. Who named pancreas? Okay, I'll go ahead. So this is Rufus from Ephesus, whatever you can spell. So he is supposed to have named given the name pancreas. Means pan is all, krias means flesh or meat. So it's all meat. That's how they thought. And final question, is there a movie named with pancreas? Anybody? It's a Japanese movie. It's based on a novel. So it's based on a novel from Yoro Shimono. So the novel was I Want to Eat Your Pancreas. An animated movie came in that name, and then it was followed by actual motion movie. So in this, actually the heroine is supposed to be suffering from pancreatic cancer. The guy falls in love, and it's the usual masala after that. So we'll go to the actual one. The theme for today is acute pancreatitis sequelae. So the first case in the series will be Dr. Sankar. He's presenting the case. He himself is presenting. So who would be the moderator for this? Dr. Basmani? Okay.
Good evening to you all. I think we are meeting after a significant hiatus. So to answer your question, I just want to read out the opening paragraph of Pancreas chapter on mastery of surgery. It says that pancreas is neither striking in appearance nor obvious in its function. Its history, its early history is hardly more than a list of names, so that no single person can. Its early history is hardly more than a list of the names of those who noticed it in their dissection before passing on to the more interesting organs. So pancreas was not at all an interesting organ. They were going for some interesting organs. Pancreas came in their way, so they just. It was only after. It was only with the demonstration of the digestive enzymes by Claude Bernard in 1850, that the pancreas came to be seen as a complete organ with an important function and thus an object worthy of study. So that is the opening statement for by Skandalakis in Mastery of Surgery. Now coming to the topic for the day, post-necrosectomy. When Patasar asked to talk about post-necrosectomy sequelae, it's a very interesting area because necrosectomy is not an easy thing, and it has a lot of complications. A person called Darman has described pancreas with such a beautiful adjectives. But I'm sure none of the surgeon will appreciate the beauty of the statement because it's very dangerous. So pancreas is surrounded by so many vital structures that when it goes for inflammation like acute necrotizing pancreatitis, we have the problems. Can anyone tell what are all the two structures that has not been mentioned in relation to the pancreas? Stomach is one. Of course, the relation of the pancreas to the stomach is utilized for interventional purposes. It's a good relation. It's a good relation. Another two structures that is not mentioned is colon and duodenojejunal flexure. These are all very awkward areas. If it gets involved, we had a lot of problems. The most common complication after necrosectomy is bleeding. This bleeding can be intraoperative or postoperative bleeding because obviously necrosectomy, the lining of the wall of necrosis is nothing but granulation tissue. It is said that the key, that's why the key word, this is for the postgraduate, the key word for necrosectomy is blunt dissection. Because you allow sufficient time for the necrosis to get demarcated from the granulation tissue so that you can do a necrosectomy safely. So you have to provide adequate time. In fact, the book says that if you do a sharp dissection, that leads to audible bleeding of fearsome magnitude. Those are all the words that are used because the wall of necrotic cavity can be traversed by some big vessels. So you should always avoid sharp dissection. Now, post-necrosectomy, you keep it drained. And the type of fluid that is going to drain out of this drain is myriad, actually. You can have, if the necrosis is close to the duodenum, you can have bilious drainage. If it is very close to the colon, you can have feculent drainage. Sometimes you can have chylous fluid. Very rarely we have seen chylous fluid. And the last is the typical spring water appearance of pure pancreatic fistula. In fact, the inevitable complication of a necrosectomy is pancreatic fistula. Because obviously, that's why it is always better to drain it internally, either by surgery or by endoscopy. But for that, the morphology of the wall of necrosis should allow you to make an endoscopic access. Now, the case that I'm going to present is a young male in the prime of his age, an alcoholic. After an alcoholic binge, he comes with acute severe necrotizing pancreatitis. He was admitted in ICU. He was there in the ICU for 15 days. He needed organ support in the form of non-invasive ventilation and some inotropic support. Subsequently, he settled after 15 days and she was shifted to the ward. He was stable, afebrile, conservative treatment continued, and he was there in the hospital for nearly 1 month. So at the end of 1 month, he was stable and he was discharged. And he was asked to come for follow-up after 10 days. Now he comes after 2 or 3 weeks, nearly 7 to 8 weeks after the onset of pancreatitis. Now he comes with mild abdominal pain. Obviously his alimentation was not good. He was not able to take a good meal. Now he started developing low-grade fever, and his pulse was around 100 per minute, hemodynamically stable. But on examination, there is a large mass in the epigastric region and extending onto the left lumbar and left iliac fossa. Large mass is there. I just want to run this. So a CT scan was done. You can see the large pleural effusion there, and you can see a large collection in the lesser sac, and that is extending onto the another big large collection into the anterior pararenal space, extending up to the left iliac fossa. Once again, I'm just running it was quite fast. There are no air pockets. So basically 2 large collections, one in the lesser sac and one in that lesser sac collection.
There's no pancreas seen.
Yeah, there's no pancreas. I'll show you. So large collections in the lesser sac, extending into the left pararenal space and into the left iliac fossa. So these are all the coronal reconstruction. You can see a large collection there. In fact, the middle panel will show you that there is an hourglass communication between the 2 collections. And as Patta was telling, you can see island of viable pancreatic parenchyma in the tail region, a small island, and there is another island in the head region. So that's that now it's 8 weeks after pancreatitis. That's the collection now. I just want Dr. Basumani, sir, you are going to moderate, or what could be the line of approach now? Now the patient is symptomatic, 8 weeks.
We need to look at the timeline. The timeline is correct now, 8 weeks, because early interventions have been shown to have more morbidity and mortality. So we need to see the number of collections. That is 2 with, even though the communication is like an aqueduct. We need to decide about intervention. Who does he need intervention? Yes. When is the time is correct? Does he need intervention because of the fever, ongoing symptoms, poor alimentation? He has got all the indications for intervention. So there is a suspected infection. Nowadays we don't need to prove infection, even with FNAC and all. If you suspect infection by clinical deterioration or fever, calcitonin, whatever, procalcitonin, whatever. Then the third is how. How is the window, Shankar alluded to the anatomy of the wall-off necrosis and its relationship. So there could be multimodal. One is through the stomach and one is through the percutaneous route. Sometimes we need even multi-gated. Even within the stomach we need one or two, more than one drainage. So looking at the anatomy and the size, we need 2 approaches, I think. One is through endoscopy and one is through percutaneous. Unless, if you do one first and then through the communication, the follow-up drainage is very satisfactory. So we can choose one to start with, but be ready to do the next one if there is no satisfactory improvement. Clinical.
Any difference of opinion? No, but when you say 2, I mean, we would rather prefer 1. Actually, if it's a communicating pseudocyst, the 1 should be good enough. Endoscopically.
So this is not pseudocyst.
Or rather, wall-off pancreatic necrosis.
Because
actually, there is no necrosis anywhere. Is there any necrosum anywhere inside the?
No.
To call the
that will MRI only will resolve that issue.
MRI only tells whether there are any solid elements.
Or endoscopic ultrasound. Thing is, for postgraduates, so true pseudocysts mostly resolve. So if you are looking at 7th week, 8th week, this kind of huge collections, pressure symptoms, and patient going downhill, it is more likely to be walled-off necrosis rather than the reassuring name of pseudocyst, sitting on it. Two, the difference between the necrosome and the liquid in the walled-off cavity is better thrown to relief by MRI rather than CT. In this place, I think CT might let you down. CT is very good for the wall characteristics, the vessels, pseudoaneurysm, large like audible bleeding, Shankar said, a major artery may be traversing the wall. So those things, but for the money construction, I will rather do both before planning intervention.
Actually, there is a aphorism that beware of a radiological diagnosis of a pseudocyst, because the so-called typical pseudocyst is extremely rare entity. Whatever you are telling as pseudocyst actually are nothing but walled-off necrosis.
I think that if you go home with that point, I think.
And that is one. And point number two is, if you want to make a diagnosis of walled-off necrosis with CT scan, you have to sit with a radiologist and measure the Hounsfield unit in different parts of the pseudocyst. What appears as a fluid may actually be solid components. So MRI is the gold standard, but CT can help provided you measure the Hounsfield units, whether it's predominantly fluid or solid components.
So that again brings the multidisciplinary. Now I said multimodality, multidisciplinary. Even for diagnosis, you need to sit and work closely with the radiologist. Surgeon, intervention endoscopist, intervention radiologist. It's a trilogy.
Sir, are you trying to tell this is amenable for endoscope? I mean, because there is the major part of the collection is in the pararenal space and into the iliac fossa, and there is a lesser sac collection, which is both of them are communicating. Are you not worried that if you do an endoscopic transgastric, you will have a problem? I'm just asking.
No, I thought first, because it's communicating, and my first intention would be is to go percutaneously and see if I cannot, or if the one above is not draining very well, then I'll go for the second intervention. Maybe as Boss said, first I would, one intervention, probably that would be
because if there is a single collection in relation to the stomach, fine, transgastric is the ideal. Because here there is another collection. So if you do a transgastric, how far you will be able to reach the iliac fossa, all those things?
That's why I thought first we should do the iliac fossa collection first. Maybe there is a chance this may drain through the hourglass. We don't know, we can't see the communication exactly, but there appears to be something. Maybe if we can drain it nicely, that's no. If it could drain very nicely, then one drainage would be enough.
But that communication, whether during surgery or endoscopy, will be able to appreciate that is very difficult.
But we should try first. First, we should try percutaneously, and if we are able to, get this down, then that's fine. More than enough.
In this patient, see, the reason why Basmani wants two interventions looks like, either one of them will not drain with one method. But then if you are really thinking of doing first intervention, it's ideal to do a endoscopic intervention because it's non-invasive. And by chance that resolves well, but which can happen.
And there is a window.
There's a window. And actually, if you see the perigastric and the lumbar are of equal size actually. Although, we generally don't see a combination of this nature. And second thing is, this is a left-sided pathology and no major structures are involved. So, I would opt for an endoscopic intervention first, and if that does decompress completely, well and good. But when you
see, endoscopic intervention, of course, it is important. The top one will have to be endoscopic, the bottom one will have to be percutaneous. The question is that if you want only one, you said you will go for gastric. I felt I'll go for percutaneous first. But, if you do the gastric, how will the one from the bottom go out? I have a feeling that it will be partially drained, and you may not have this full drainage. Maybe we should try percutaneous first, the iliac drainage, which may drain the gastric.
The second thing is, like, if you do a percutaneous intervention and the gastric one decompresses a little bit, but still there,
that you may go in
the efficacy of the bulge or whatever, little less than what is generally? I mean,
Excuse me, sir. In our institute, we have used two PCDs, percutaneous drainage. One in the flank and the another one. Sometimes our intervention radiologist used to put transgastric through and through. And we have managed like that many patients. Suppose first I will prefer putting a tube in the flank collection. If it is not draining, is another method. Instead of endoscopy, you can just, if it is accessible without damaging the stomach, we can put another in the epigastric region. And if it is not, we have placed many patients transgastric through and through, anterior and posterior wall, and without much problem. Sometimes we used to irrigate through the epigastric collection. If you give saline, it will come through, it will irrigate the cavity also.
Okay. So, Justin sir, any MRI not done?
So, basically, as you said, whenever we are thinking in terms of necrosectomy, I always prefer a surgical approach as a first choice, particularly in the after 8 weeks. And because I feel endoscopy or intervention, it is one is we are going to introduce the infection first. Whatever the sterile necrosis became a infected necrosis. So the things we are keep on repeatedly doing multiple procedures. So 8 weeks is ideal duration for a surgical option. Okay. If there is a significant amount of necrosis. If there is a clear fluid, if any method which shows the necrosis is less than 10%, we can either aim for an endoscopic or percutaneous. If it is a significant amount of necrosis, I would opt for a surgical approach.
So it's a very interesting situation. A surgeon telling endoscopy and an endoscopy telling surgeon surgery.
See, surgery, suppose if you're thinking of a cystogastrostomy, for instance, still it may not take care of this.
It is not a cystogastrostomy, it is more of necrosectomy, because I don't think it is...
necrosectomy through a cystogastrostomy is what we do. This we may not be able to approach, this left collection. You know, the same thing holds good. That's a brilliant idea, actually. I didn't expect this to come this way. Just, would you...
Some necrosis. More necrosis.
It's a walled off necrosis, sir. It's not a pseudocyst. CT scan shows lot of debris. Okay. But there is no infection, there is no air pocket, but patient is now slow. Now it's 8 weeks. He has developed temperature.
8 weeks, man. Preferably go up.
Doesn't mean infection.
Pardon, sir?
Temperature doesn't mean infection.
It means what? At 8 weeks?
No, some inflammatory activity. I don't know.
That's all the first 2 weeks, sir. 8 weeks is, we know that it's infection mostly.
Shankar sir, so even if I think with the step-up approach or the guideline says that we have to first go a percutaneous drainage rather than direct surgery and then try for surgery, the only thing is that the drain should be placed maximum from the retroperitoneoscopic approach so that we can go for a ward if in case.
Okay. So
step up approach.
I think what Ilan is telling is step-up approach, but it is almost 8 weeks. Step-up approach comes when you start intervening by 4th week, 5th week, 6th week. So it's 8 weeks. That means it's a time period is ripe enough for you to do a right royal necrosectomy, either minimally invasive or an endoscopic approach. And this particular, the morphology of the collection cries for a percutaneous approach through the lumbar.
So beyond 6 to 8 weeks, when it's a ward of necrosis, go for single stage procedure. What approach is the best?
Yeah. So the more time you take, it might be a single time procedure because the necrosis has demarcated from the granulation tissue. So shall we move, sir?
Just one point to what Sendil said of 2 drains, I think is too much of a discomfort for the patient. I wouldn't think of having 2 drains. You know, these drains completely don't drain and they have to be there for a long time. Now, why I was thinking of endoscopy first and wait and see whether we are required to, because, you know, there is nothing on the abdomen if you really the comfort part of the patient. If you can endoscopically do something and after that, still, this doesn't resolve, then you go in and do. Even this, now when you're talking about necrosectomy, how can you do necrosectomy, whatever, through percutaneous route for this? The same thing holds good actually.
That will be an next case.
Yeah.
Yeah, we can do this is ideal for a retroperitoneal approach.
That includes the the gastric part.
That's a caveat. Whether we can go through that communication is the question. That's a caveat is there.
Because the DJ, duodenum and all come in room.
Yeah. So whether if you are able to negotiate that communication, then the
Youngsters have any comment to make? Yeah, boss. Before you. So let's the cat on the back.
No, I'm supposed to be moderating. So
Any of you have experience like putting drainage and this collection, keeping it for long time, disappeared? Because I have seen two patients, one in SIMS and one in Anaral. Large collection, keeping drains for long time, keeping it patent, and then slowly with drain itself, without surgery, patient settled. One patient in SIMS, it happened. Anybody, any of you have that experience? Yeah.
Sometimes that will end up with the fistula. He may end up with the pancreatic stenting. So only putting it, only drain may be
Drain and upsizing it if needed.
See, by literature, at least 1/3 should do well just with drain. By literature. So practically, I don't know how far it works, but the one, I mean, that's the reason why the step-up approach actually came into vogue, because they feel that a surgical necrosectomy or a formal necrosectomy may not be required in up to 1/3 of patients. But the only question in practical sense is that may take a long time. People are not, I mean, people as well as the doctors are not willing enough to stay that long in the hospital, antibiotics, you need something to be done quickly. Like as you said, if you just place a drain, it's going to take weeks and weeks for it to drain. So all that come into picture when you take a call on what you want to do. This, as you said, it can be managed both the ways. I think a transgastric approach to drain the lesser sac as well as a percutaneous thing. But what I would prefer is to have a drain placed before I put a transgastric drain, a percutaneous drain in place. Because sometimes once you put a percutaneous drain and most of it drains out, then there is nothing for us to go through to the transgastric approach. So a combination approach can possible in a non-surgical way, but I think surgery possible. I think with the retroperitoneal, that nice window possibly it may be possible. I think. But the final point comes to what the finances is. How long?
In contrary, for the retroperitoneoscopic debridement, we prefer the drain to be placed before surgery, well before surgery. Correct. Why? Because that's the same track we go for the approach, and second is sometimes you can inflate the collection sac with methylene blue to actually expose
the so-called what Prema was telling is the Panther trial from the Dutch group. See, for a step-up approach where 1/3 of the patients can be avoiding a surgical necrosectomy, for that you need an aggressive radiologist. So the success of a step-up approach depends upon the aggressive radiologist.
Also, so to summarize, so we have multiple options. Multi-modality, multi-gated. You said one modality, 2 gates. So one percutaneous modality to 2 gates. But don't forget antibiotics, nutrition. That itself will resolve 10 to 15% of patients, not at this stage. And then if you choose step-up approach, again, Prema touched very important point. Everything depends upon the expertise, affordability, and patient's willingness. Patients and the family's willingness to go through the options. When you have multiple options, then it's better to tailor it as per the patient need, affordability, expertise, and for example, instead of doing 2 procedures quickly, one after another, do one and then wait for the improvement and things. So never underestimate the healing power of the body itself. So like he gave the example. So when the patient waits long, sometimes they heal. But if they don't improve, then you need to step up.
The surgeons draining, doing necrosectomy like minimally invasive approach to the drain site. In this case, it will be difficult because the collection is significant collection in the epigastric region in the lesser sac. It's very difficult, and many times we end up doing repeated necrosectomy. Repeated procedure. It's not like single time surgery. Necrosectomy patient, they stay in hospital for a long time, and then the drains also after necrosectomy we have to keep the drains for a long time. So this patient that is not possible.
No. What are you trying to tell?
So surgery is going to be difficult.
So what is the option?
place the drain and then minimally like step-up approach.
Okay, fine. But that's
in effect, one single modality may not be enough to completely make the patient all right. A combination, in spite of surgery, there may be one area which cannot be drained surgically, that might require intervention.
You intervene, assess the efficacy, and then tailor it. No, don't assume that what you will do will work for the patient.
Okay, shall we? I'll show you. So actually, what we did was we took the patient for surgery. Since it's protruding into the iliac fossa, we made a small incision, and once you open the cavity, you got nearly 2.5 liters to 3 liters of fluid, and we tried different techniques like we used a Sills port. Sills port is a single incision port, and try to give wash and do a necrosectomy, and that Sills port was not fitting into that area correctly, so we used a laparoscopic instruments. Though the vision is poor, but still we did a necrosectomy, and we are able to remove some amount of necrosis through a lumbar incision, through a iliac fossa incision, a small incision, retroperitoneal approach, because it was protruding into the pointing there. But only thing is, we are not sure whether we have negotiated that communication, that small communication. So, but we placed it at the end of the necrosectomy. We placed 2 drains, 28 French flexocath, and so that we'll irrigate the drain, and we expect that this communication will help so that the retrogastric collection also will drain. That's a wishful thought. Okay. Then what happened was, so patient improved after the procedure. 2 drains were placed. Obviously, the drain output was purulent fluid, infected pancreatic juice was pouring out. Nearly each drain was putting out 150 ml. And this is my observation. When you have a florid necrosis, the amount of pus that is pouring out of the drain is mind-boggling. Something like a achaya patram, where this pus is going to, it keeps on coming like anything, it never stops. So antibiotic was started as per culture sensitivity, and the patient initially improved for the 1 week, and now almost it is 15 days after the necrosectomy. He once again started spiking temperature. We used the irrigation of the drain to unclog the drain, but the drainage was continuous. There is no reduction in the quantity of drain. But now he started developing. So 15 days after necrosectomy. So what would be the run-down? So we have done a retroperitoneal necrosectomy, 15 days. Once again,
question: what is your starting antibiotic, and your escalation is based on what protocol? Is it blood culture, or is
I think that's not the.
We had image now. We need image.
I don't. Yeah. See, because obviously, since patient is having temperature, it's obviously incomplete.
Surgical means we expect at least a hair total. So this kind of minimally invasive surgery means that is a kind of like a step up approach.
Yeah. No, since 8 weeks was the timeline, our aim was to do a total necrosectomy, but it didn't happen. It didn't happen because
I think approach was not right.
Yeah,
if you want to do a complete necrosectomy, you have to do a laparotomy.
No, that's what
Or you'll have to go for multiple approaches.
Sankar, you tried doing a minimally invasive approach. You said you lost vision and other things.
Yeah.
So you certainly would have been uncomfortable knowing that there is not going to be complete drainage or full completion. So at that point, do you think we should have gone for laparotomy fully to, as Ubal is asking, like,
Sir, laparotomy, I mean, see, what is step-up approach? You drain it percutaneously, you put multiple drains and irrigate. And we know that we know the morphology of the collection, that these are all communicating. So since we have placed 2 large drains, 28 size, we expect that whatever that is not drained during necrosectomy will drain out. You understand?
Actually, there are 2 collections. The primary collection is in the lesser sac, which is the main problem. And there is a secondary collection in the iliac fossa. And we have addressed the secondary collections, and we have left behind the primary collection.
No, there is nothing primary or secondary. I think the large collection was in the iliac fossa.
Usually, this is only fluid in the iliac fossa, whereas the necrosum is in the lesser sac.
Okay.
That's what we usually find.
That's correct.
So, how different was the surgery to just a percutaneous drainage? Like, what was the advantage in doing the surgery for the iliac fossa collection, which could have been handled with the percutaneous drainage?
No, normally you put a drain into you allow the drain to mature, use the tract and then use a nephroscope and do a debridement. We are not, I'm not trained in doing a nephroscopic debridement, so we use the laparoscopic instruments. Though the vision may not be optimal, so we just did a irrigation and tried to wash it out. And because it is already 8 weeks, we expect that necrosis would have demarcated. So that will come out.
So anyway, at this juncture, since patient is running temperature again, one is remnant necrosum, infected, whatever, or a second possibility is a gut communication somewhere.
Pardon, sir?
Gut communication.
Fistula.
Wall fistula somewhere.
Okay. So
we need to look for these 2.
So what I would share with postgraduates is, Sankar said pus keeps pouring out. Have you cared for patients with severe burns? 6th day, 7th day dressing. So it's a chemical burn. So corrosive juices have burnt the peritoneum. We are talking about a large area of internal burn with necrosis. So treat it as an internal burn. So that's why this necrosum and the pus is not unexpected. So very, very wretched disease. It's an internal chemical burn.
And that creamy whatever pus shouldn't be chyle. Chyle is another thing we should
No, it's not chyle. It's an infected pancreatic juice. It's an infected pancreatic juice that was draining. Okay, I mean now we have to do a repeat imaging. You all agree with that? Yeah. So we did a repeat imaging and all of that.
Why not MR now? Why are you going back to CT?
That's okay, sir. Large pleural efficient is there. You can see the retrogastric collection has come down in size, but still that's a residual thing. The retroperitoneal collection has completely reduced with a very minimal residue. Once again, I'll just run it.
There are a lot of gas bubbles in the
retrogastric area. That's because you do irrigation with that 2 drains, no? But it may also be because of an infection there. So
the call for anterior surgical intervention.
The retrogastric collection has reduced, but its residual is there. And now the new point is it has air pockets, which indicates it could be infection. Or it could be because of our manipulating the drain also. Because the drain is open, we are daily disconnecting, irrigating it. So that is the situation after 15 days.
But if the patient is having fever and not doing well, it's better to assume infection.
Now what to do, sir? And I think if you see the lesser sac collection, Ubal, you do you think it is endoscopically accessible and can do a good work now? Pata is telling no.
Now at this juncture, if you see a lot of solid material in the retrogastric area, a lot of gas bubbles, this will require surgical intervention.
No, again, what kind of surgery?
Laparotomy or other anterior approach, and then transgastric and do a necrosectomy. See, earlier intervention.
That's what I thought the initial procedure should be.
If that was done, this wouldn't have been cleared.
No, that's what I said, because the surgeon is becoming less aggressive and endoscopy becoming more aggressive. That has happened over the period of pancreatology, over a period of time.
And that is the dictum.
No, that is making the patient trouble. The problem is this patient, if underwent a full laparotomy and necrosectomy, the problem, you say 8 weeks is the ideal time for a proper surgery. It is not a 3 weeks, 4 weeks we are not dealing with.
Huge procedure, I'll tell you, when open the entire abdomen.
Not at 8 weeks, not at 8 weeks. I don't think so. Because the amount of collection, the necrosis, the amount of necrosis, what surgically can be done cannot be replaced with any other methods, even including the minimally invasive surgical approach. Because that kind of approach makes the patient more troublesome, making repeated procedures. See, we are worried about the outcome in the initial first 2-3 weeks. That is understandable, but not at 8 to 9 weeks.
Okay.
No,
At this juncture, what is that you want to do is what Shankar wants to
No,
do. I say surgery, what do you say?
I partly agree with you, but I mostly disagree with you because...
That's okay.
No.
Because I came across so many surgeons over a period of time. I know how aggressive surgeons were initially, now how the surgeons become... I know that pancreatic is a very difficult area to deal with, but not at the 8-9 weeks. At this point of time, surgeons should be more aggressive.
No. So the surgical necrosectomy by open surgery is met with a lot of mortality. Okay, it's not like just because 8 weeks is over, you will have a cakewalk there. It's not like that.
Not a cakewalk. At least open access must have done a 90% necrosectomy in this case.
Yeah, that could have happened. But thing is,
because now we are come back to the step down. See, basically we need an endoscopic ultrasound to assess what is the collection in there and whether it can be accessed through the, because again is going for one more surgery is very unlikely result in a major benefit.
Thing is, Ubal, surgery, suppose you have the necrosis in the crevices of the root of the mesentery, root of the mesocolon. These are all very difficult areas. Maybe your point is like you can do a 90% necrosectomy. It will not be complete, and even these such a massive necrosis, they don't do well with the open necrosectomy. That's the whole thing. So why the world has moved towards minimally invasive is open necrosectomy carried a very high mortality. And it's not like if it's a single collection, it's fine. If we have multiloculated collection, that's a problem.
This I feel if we do an open necrosectomy, it must be a single collection. I don't think it is a two collection.
No, it is two collections.
Two collection by imaging, but I feel it is a single collection.
Then next time we have to do necrosectomy, we have to call him only.
See, surgery is such a messy thing, I'll tell you. Smelly, messy, and you'll have the scar, the thing don't heal properly. They'll heal with a ventral hernia, the wound will be infected, and the abdomen will not be able to close sometime, the bowels will be... I would not like to operate on this patient at any cost. Now, at this juncture, we have no choice because he's got some solid material. Senthil, what is your take now? At this juncture, what would you do?
So in this patient, I will put drains first 8 weeks or 10 weeks.
No, don't go back.
I can put drain in the epigastric collection.
Drain the epigastric, what percutaneous?
Percutaneous.
I will ask Brahma, at this juncture when there is a lot of air bubble, how friendly that will be for US?
US will be difficult. Now, that's what I told you. When we plan first also, even initially also, it is better to put a drain, transgastrically approach, but if you have to plan for a percutaneous, put a percutaneous drain, but keep it closed so that we can drain it transgastrically. Now with so much of air, it is not that it is impossible. There are certain groups which still go, instill saline, make it into a very visible collection and then puncture. So it is not that it is impossible, but it will be difficult.
He is already telling I'm taking more time. So we'll go.
You are.
Okay.
Interestingly enough, there's so much difference of opinion for a simple patient of this nature.
It's not a simple patient, sir.
Surgeons don't want to operate and the physicians want to operate. That's a problem. We want to operate, but we don't operate. No, ourselves. Shankar, then time.
I think thing is that's why in Asian Institute of Gastroenterology, all walled off necrosis are discussed in a multidisciplinary team and then decided. So it's actually good. We have to balance it out. Now, so what I did was what I did was I just removed the drain and I used the same small lumbar, that is a lumbar incision. I tried to pass once again laparoscope and gave a wash, and the best, the blunt dissection best is finger. Finger is the safest and blunt instrument, and we removed a lot of necrosis. You can see how much amount of necrosis is coming out. That's a pancreatic sequestrum. That's and lot of that's a small incision, that is the lumbar incision. And then we once again gave a wash. Show the necrosis, the lot of necrosis was there. So as Ubal said, the first necrosectomy was a little incomplete. So that's the.
Now, can you reach the retrogastric area?
Now also we used a laparoscope to area and gave a wash and repeatedly, and you now use the fingers. Now something like a step-up approach only, but that's what we did. Now post-operatively, the drain was showing blood, and there was a drop in the hemoglobin. So for which we have to give transfusion, 2 units of transfusion, and then the bleeding stopped. And then the drain was putting out seropurulent fluid. It was going on for another 3 weeks. We are not able to remove the drain. So what will you suggest? No, there is no fever. He's taking diet, but drain was amylase was grossly elevated. It's a pancreatic fistula. Okay.
Now, this fluid will not be corrosive or it will not cause any skin excoriation. It's a pure bile.
Yeah.
Like if it's bile, that is. I mean, that can go on forever. At some point of time, if because there's hardly any pancreas, if pancreas reformed, and there is some point in stenting the pancreatic duct.
So now he is already there in the hospital for 1.5 months. Now he is stable. He wanted to go home and come back. Can we discharge the patient? So, no, we can't discharge the drain because drain can erode into blood vessel. So we remove the drain, we put a stoma back, and then we discharge the patient. Pardon, sir? It will form a collection. Okay. Repeat imaging was not done. Now you are advising before discharge we have to do repeat imaging. Yeah, already too many CT scans, money, lot of factors are there. Okay. Foley's catheter. Okay, fine.
See,
now
in this patient, Shankar, I mean, we'll not have any. Suppose there's some point in imaging, with the way you go taking the story, I'm worried that something's going to explode now. And
you know me well.
Otherwise, you would not take this thing up. Now, there's some point in what he says. Suppose if we have some sort of pseudoaneurysm at this juncture, then we know that we are sitting on a time bomb.
Correct.
If you're not done it and suddenly something happens, what will you control? Where will you control?
Correct. So ideally, you have to do a imaging, but since the patient was stable and we thought let him go back and come after 10 days. But this guy goes back and comes after 10 days with fecal fistula. After going home, he was okay for 4 or 5 days. And subsequently, he was putting out feces through you told bowel communication. So he was pouring out feces. But this guy was not coming immediately. Doctor has told 10 days, I will come after 10 days. When he came, he was very sick. He was very in a bad shape, and we have to really resuscitate him. And we did a laparotomy. Now we did a laparotomy. So now we did a laparotomy, and we did a.
This is damage control.
No, Ubal, you didn't say you didn't suspect bowel, no? You didn't expect this complication.
It can happen at any time.
It cannot.
Whatever the minimal invasive surgery, because whatever you do is blindly you do. So these kind of complications can be expected.
But colonic complications are just 5% in the necrosectomy. It's not that we expect on a day-to-day basis. That's what I want to ask, sir. You go for a prophylactic ileostomy, sir. because in the last 20 years of my experience in surgical gastroenterology, especially pancreatic necrosis, we have had 6 patients with colonic involvement. And actually, this when you do open necrosectomy, invariably when you do necrosectomy, you injure the colon or DJ flexure. See, that's what we are worried. When you try to do it, no, it's not, surgery is not easy. You may injure the colon.
No,
and that time we may have to do a diversion.
This patient doing a prophylactic ileostomy may not save us, because when you try to put your hand from left iliac fossa to the right hypochondrium, you can injure the duodenum also. If you do an ileostomy, how is the duodenal injury or any small bowel injury going to help?
No, sir. You are imagining.
We have to imagine, obviously. I'm a surgeon.
I'm not a Morphan's to put my finger up to right hypochondrium.
Then there's incomplete necrosectomy.
No, the second
if your finger is only reaching up to less than splenic flexure, how are you dealing with it?
We are using a combination of laparoscopic instrument.
Right.
See, it's not, we can't reach that area.
Right.
So we use the instruments, blunt instruments, suction.
My point
it's a combination.
The prophylactic ileostomy concept, is little dicey. I always feel that if we have colonic leaks are not fatal. Small bowel leaks can be fatal. Colonic leaks can always be, whenever we had a patient, we took that time, did a ileostomy, the colonic things healed.
Okay, sir. I think I'll wind up. So colonic involvement.
Let's have some more opinions on this.
Sir, the injury to the colon or the duodenum need not be iatrogenic. Sometimes necrosis can injure the wall, and when you remove it, that support is gone and it will go.
So that's what colonic involvement is nearly 6%. It can be because of various reasons. It need not be iatrogenic. It can be the extensive retroperitoneal suppuration and pancreatic juice itself can lead on to that. Sometimes you can have micro perforations, but I disagree with the user. Colonic involvement literature says has high mortality, and whether to do a preemptive diversion, as Professor Jaswant was telling, whether to do a preemptive diversion, that's actually a good. For that, you have to sit with the radiologist and look for any subtle involvement of the bowel, and whether to do a colonic resection or just a diversion. I think better to do a diversion unless the colon is there is a gangrene of the colon or ischemia to the colon. So I just presented this case with the purpose of, you told post necrosectomy sequelae. I thought colonic involvement is one thing which, but your point is well taken, sir. Colonic involvement is at least manageable. Suppose you injure the DJ flexure, you had it. Because at least colon you can divert. DJ flexure is a difficult area. You can neither do a resection nor you can do a diversion. So that's a very.
Anyway, I'm a little relaxed. I was expecting some aneurysm rupture.
Okay.
It didn't happen. I mean, that would have been a very difficult thing, but at least patient survived.
That aneurysm for another day, sir. Thank you, sir.
Thank you.